February is American Heart Month. We thought it was the perfect time to revisit a few of our favorite conversations about heart care and innovation. You'll hear segments from 3 previous episodes that show just how far cardiovascular innovation at OSF HealthCare has come. These stories range from using AI to uncover hidden genetic risks, to a groundbreaking procedure that saved a toddler's life, to remarkable new 4D heart models that help surgeons plan complex procedures. It's a great lineup and a powerful look at how technology, creativity, and collaboration are shaping the future of cardiovascular care. I'm Shelley Dankoff, your host for OSF HealthCare Accelerated. We appreciate you tuning in and remind you to be sure to subscribe, rate, and review wherever you get your podcast. Personalized medicine. Think about it. If you can get healthcare specifically tailored to you, your family, especially if it can make a positive impact on your life, most of us would do that, right? Through OSF Innovation, we are working every day toward that level of care, leveraging big data to tailor unique care to individuals. One of those areas has to do with your heart. It's called familial hypercholesterolemia, or FH, as I will refer to it throughout the rest of this show, which is a genetic predisposition to high LDL, what's known as the bad cholesterol, and can cause heart attacks in younger people. And when I say younger people, we're talking 20s and 30s. It's that young. Joining us for this conversation are Dr. Daryl Gum, a cardiologist and the vice president of the OSF HealthCare Cardiovascular Institute, and Ryan Loudermilk, strategic program manager in our Ministry Performance Improvement Division. Before we take a deeper dive, welcome to both of you. And Dr. Gum, I want to start with the health perspectives of it. As a cardiologist, tell me about FH and why how it works and how it affects someone.
Yeah. Thanks so much, Shelley. FH is, first of all, way more common than we thought. About 1 in 200 people have it. And that means it affects about 1.3 million Americans. We estimate that about 10% are aware that they have it. So a huge gap in knowledge. And to know it, it's very treatable. But if you don't know, you don't get it treated. So and of course, the consequence of untreated high LDL, we know that LDL is the particle that gets in the vessel wall and creates plaque. So untreated LDL that's running very, very high is rapidly building up plaque in people's arteries. Of course, the most fatal would be the heart, but carotid arteries and elsewhere, the legs, et cetera.
And that's one of the biggest challenges, isn't it, Ryan, that people just don't know what they don't know, right? Because I think there was a certain generation, you didn't ask those questions. Oh, we do. Grandma and grandpa dealt with that. And you'd hear stories, you'd hear tales, but nobody talked about that. Is some of that what we're also trying to break those walls down to?
Sure. I mean, you could be walking around healthy and have no idea that this is going on in your body, especially when you're younger, and you could be an athlete and have no idea. You basically have this ticking time bomb really going on in your body. So that's what makes it so challenging for us to identify.
And you're right. We have these patients. We have people who say, I don't want to get my blood tested. I don't want to know that. I equate that to saying, I'm going to put a blindfold on and walk across the street because there might be a bus coming, and I don't want to see that coming. Okay.
Yeah.
If you've got high LDL, there's a bus coming. You're walking across the street blindly. You should know it, and then you can take the proper steps to prevent a disaster.
And that it's as simple as a blood test, right? This is not some other invasive thing. It is a boom, draw when you're getting the full range of blood done.
It's a fasting blood sample that will tell us a person's baseline cholesterol, which that panel will include their LDL. If you have FH, you will have, everybody should be eating heart healthy and living a healthy heart healthy lifestyle, but it will not change the outcome for FH. These people are going to make way too much LDL, and they will get in trouble as a result of that.
And how is it treated?
It's treated with statins typically, but statins and a variety of other medications that we have, particularly the PCSK9 inhibitors, a new injectable form of treatment that's available as well, that dramatically affect the LDL. I mean, we lower a person's risk, just with statins alone, we can lower the risk of a cardiac event or stroke by up to 80%. I mean, it's tremendous.
Wow, that's a significant number to throw out.
And just stopping your McDonald's visit isn't going to be enough to make that difference. I'm trying to remember, there's an old Chinese proverb about doctors. An average doctor treats the full-blown disease. A really good doctor catches it early, and an excellent doctor prevents the disease from ever happening. And that's where we're heading. And that's where we're really going to have a huge impact on a lot of people's lives.
Being innovative sometimes means being willing to do something different, perhaps using a device in a way it hasn't been used before. That's exactly what a team at OSF HealthCare Children's Hospital of Illinois in Peoria did to save a young child's life. Joining us to talk about this remarkable achievement are Dr. Mark Plunkett, Chief of Pediatric and Congenital Heart Surgery, and Dr. Sunita Ferns, the Director of Pediatric and Adult Congenital Electrophysiology at OSF Children's Hospital of Illinois. Thank you both for being with us. I've been looking forward to this conversation because the teams at Children's Hospital do such great things. So it's great when we can talk about really cool stuff. But this particular case actually started with some quick thinking parents, didn't it?
It most certainly did. And when the mom realized that her child was having a cardiac arrest, she jumped in, started CPR, and really that's what saved this little boy's life. So Brugada syndrome is a very rare channelopathy. It's due to a mutation in a sodium channel. And our heart, like our brain, has ion channels. And when there's a certain channel that loses function, that causes malignant arrhythmias. And that's really the pathogenesis. It's a genetic mutation. And so in this particular child, he was the first one in his family who had it.
Interesting. So if this didn't happen, they never would have known. He potentially could have gone through life, or was it going to show up at some point?
And, at this age, the particular presentation of Brugada can be very malignant, and oftentimes children don't survive an arrest. And so if you think about sudden infant death syndrome, crib deaths, about 30% of them could be attributable to channelopathies like this. This little boy was very fortunate that his parents knew what to do and jumped in immediately and saved his life.
Let's turn to the device itself, the EVICD. Now, in the past, this has only been used on older teens and adults. It had never been used on a child this young. What is the device? How does it work? What is it designed to do? Tell me about that.
So if you've seen these yellow or red boxes in the field, they're called defibrillators. They're
Right.
external defibrillators. And what an automatic defibrillator does is it provides a shock that jolts your heart back into a normal rhythm. And so what this little device does is it holds that power to be able to shock a child or an adult out of an abnormal rhythm to sync their heart back in rhythm again.
It sounds, and again, I'm going to turn to the surgeon here. So when it comes to putting this in, but how did you guys come up with the thought of this could work in this young child when this had never been used that way before?
Right, and this is called an EVICD, which is an extravascular implantable cardioverter defibrillator, okay? And many of them are implantable, but they have to be placed in the vascular system. So as the patients get smaller and younger, that becomes very problematic. The great thing about this device is that it sits, you can put it in almost a minimally invasive approach. It sits below the breastbone or the sternum. It doesn't have to actually sit on the heart. You don't have to open the pericardium. And then the generator can be placed somewhere close by, usually in the upper abdomen in the older patients, but we had to put this one in the armpit, if you will, the axilla, because that was the best place to put this, the generator or the battery. It'll also allow him to grow without the need for replacing it anytime soon, as there won't be too much tension between the device inside and the generator.
How did it cross your mind to even use it? Again, it had never been used in a child like this, but you knew what the device was designed to do. Did you just, because what would have been a typical treatment otherwise for Brugada?
The child would have needed an ICD, but prior to this device being available and us having decided to at least trial it, what we would have done was we would have involved a cardiac surgeon, such as Dr. Plunkett. He would have had to perform open the child's chest, open up the child's pericardium, which is a sac that surrounds the heart, and tack some, pretty hefty leads on the child's heart. And then the device would actually sit in the abdomen. So the device would go across two body cavities. And so when the child grows, there's tension on that wire that Dr. Plunkett would have to tack down. So it's a very tedious procedure to put a device, an implantable defibrillator in a child this young. So how did we think it could work? It was just it was an idea. I wanted to know if the lead would actually fit the child. So I taped it onto his chest and I got an x-ray done and it just about fit him. And I said, it looks like it'll fit and we can keep it hidden behind the breastbone. So let's try it. We, of course, had a backup, traditional system in the operating room. And that was available. And we always trial these devices. So once we put them in, we put the child knowingly into a life-threatening rhythm. We let the device shock him to make sure that he can get out of it, because really we want to make sure it works before we let him go.
Yeah, and I have to give Dr. Ferns credit for calling this to our attention, but I immediately jumped at it as a great idea, knowing what we would have to do otherwise to implant the older devices, which, as she said, would require major operation, opening the chest either through a sternotomy or thoracotomy, accessing the heart, putting in either coils or patches and that sort of thing. And those devices are not as effective. Those are older technology. This device is much more effective. And can be placed with a much more minimal operation.
Yeah, the other way is full-blown open heart surgery, right? And that opens you to even other things like infections and stuff. Just anytime you're doing more extensive stuff, there's other things that can happen.
Exactly. And if I'm correct, this baby went home like in a day or two after the operation. So that says a lot right there as far as the difference versus staying days to weeks after a more major procedure.
Yeah, it's scary to think you need to put a defibrillator into a child, but it's nice to know that it exists. So you've published a paper on this, and so it's out there. Have we been contacted by others about the use of this, and are they going, okay, let's discuss this? Have you heard from others?
Sure, yes, and it was published in the Annals of Thoracic Surgery, and we made a very descriptive report so that others could read it and understand what we did. But yes, we've been contacted quite a bit, and many asking how our patients doing so that they can use the device in the same way.
And as such, like we spoke about before, it's just so incredibly rare for a child to survive a cardiac arrest like this in the field and to have, to be neurologically intact. And we've had some other centers that have reached out because they've had a toddler or an infant who presents like this, and they've asked us what our experience has been and, asked for our input. So I think it has opened, it's opened the door to using this device for much younger kids.
Okay, so let me ask the question, how is the patient doing?
The device has saved his life at least twice, so he's doing incredibly well. He has a particular syndrome, and we need to. The point of having a device is not to let the child keep getting shocked, but it's really a safety net. And so our aim is to work on his medications such that we don't reach the situation where the child gets a shock. And so we've been adjusting his medications, but really what the devices allowed us to do is to do that safely.
Yeah, but like you described earlier, he can have a typical lifestyle. So he'd be able to go out and do everything every other kid does.
Yes, and it could be possibly in the future as he gets older and bigger, if we have to change the generator out, we might move it from his armpit and put it somewhere a little,
less you could bang into it as a kid.
Exactly.
Yeah.
Yes,
okay.
A little bit out of the way for as for his activity and things.
Since 2013, the Advanced Imaging and Modeling, also known as AIM Lab at OSF Innovation, has grown beyond imagination. Since 2014, they have created more than 220 3D hearts for pre-surgical planning at OSF HealthCare and several dozen more for well-known medical institutions around the country. While that is exciting, even more so is the fact that OSF HealthCare is now home to the only lab in the nation with the capability to automate the creation of 4D beating heart models. Joining me to talk about this is Dr. Matthew Bramlett, a pediatric cardiologist and the director of the AIM Lab at OSF Innovation. So let's back this up a little bit and start with the 3D heart modeling and the establishment of the heart library there. Take me back about a dozen plus years and then how we got from there to where we are today.
Well, I've told this story many times before, but when Jump said that they had a 3D printer, we were like, stop the presses. I've got all these hearts waiting to be printed. So I'm a pediatric cardiologist and I do cardiac MRI and CT. So that's sort of the role I play in my subspecialty. And so my area of expertise is to generate these complex 3D MRI data sets. And we took those and essentially cut the heart out and generated a 3D model. The first time we ever did that, back in 2014, for the surgeon to hold in his hands before he went to the operating room. It was expected to be a standard case, but we wanted to show it. It changed the surgery. So we caught lightning in a bottle. We instantly realized that there's value in that three-dimensional understanding. And so over the past decade, we have continued to provide this service for the Children's Hospital here as well as elsewhere, and worked with the NIH to initiate the 3D Heart Library, which is a repository of many of our models for education purposes around the U.S.
So now how do we translate that? Because that's what you're holding it in your hand, and now you've taken it a step further, a 4D beating heart model. This just sounds cool beyond belief. Tell me about the development of that.
One great example, we've done, I think the actual number is like 235 hearts, 3D hearts for pre-surgical planning to date. Within a week, we had doubled that number because of this technology. So we had been able to almost immediately, because at one patient would give us 20. And so it was just like, we were able to crank these out to generate these models. And so the question now is, how are we using it in real applications for these problems that a 3D just doesn't quite deliver for us? I mentioned how it's doing better than what the human was doing. One of the surprises, which it plays into this example I'm going to tell you, is it's showing us the valves. So a CT scan, the valves are they're moving, and especially in end diastole, they may flutter a little bit, and that motions, they sort of get lost in the shuffle, and you don't pick it up very much. Your brain is an amazing tool, and think of it like a 3D connect the dots. As those dots are filled in, it may not be the entire valve, but your brain, as it's moving, puts it together. And so we're seeing valves from CT that are not something we trained it on, nor did we expect to find it. However, it's a critical part of many of these problems that we encounter because the valves are dynamic. So we recently had and this is the example I was going to tell you. We recently had a very complex congenital heart patient who, in many instances of congenital heart disease, multiple institutions will weigh in on what to do. And so we had our two surgeons in our surgery conference. We reviewed this case, came up with, here's plan A. Other advocate in Chicago, Lurie's in Chicago, surgeon at one, two surgeons the other, did the same thing. Everyone said surgery A. Then I put our surgeons through the 4D heart so they could look at it. They both came out, said surgery B. I drove up to Advocate, put the surgeon through the same thing, surgery B. Lurie, surgery B, surgery B. And so it was the dynamic nature of this very complex heart with the valve in view that revealed the whole problem. And I'm sitting there in surgery conference, and I'm trying to perform research and make a point here. And so like they're saying, well, surgery A, and I said, well, as long as we're going to look at the 4D, because I'd already seen it, I knew surgery A was not an option. Because one of the things I've learned is that this field still seems a little nuanced to many people. I don't think, and especially in pediatric cardiology, I think it's elevated beyond the fad. They understand there's value here, but there's still a point of convincing a very confident surgeon of the value. Sure. And the cases where they go in thinking A and coming out B are the ones that lock people down. And in fact, one of the surgeons was like, I was a skeptic of this technology before, but in this one case, you've now convinced me that this is the future. This is the next level. I like to consider it the next imaging modality, really.
So, and I know you could talk all day about this because it's very exciting. I hear the excitement in your voice as we discuss this. What excites you most down the road? Is it those aha moments for people? Is it all of that stuff? Or is it the potential of what lies ahead with this technology that we haven't even scratched the surface of?
People have to experience it to believe it, without a doubt. And so in order for people to experience it, they have to have access to it. And for them to have access to it, the tools need to be better with a lower barrier of entry. And that's our research, is this automated segmentation using machine learning. It took us 5 years to do the first one. It took us 2 years to do the second. Which was this one. And it was like trial and error until like the very end where we nailed it. But this summer we brought in a summer intern, and the summer intern in weeks did our third model. And that's the whole lab, like all of the resources we have available to us, what we have learned in doing this. And I think that's a major differentiator between our program and many other hospital programs out there, because they're performing the segmentations, they're doing manual work, they're generating this, but they don't have that linkage to the incredible engineering, in-house staff and research staff to solve these barriers to entry. Because now, while we did this to get this 4D heart, we use it in all our cases now. So instead of sitting down at the computer and performing this manual segmentation, we're clicking a button and rolling with it. So now we have a whole list of, we need, brain, lung, bone, we know how to do it, and we're knocking them off the list.
Well, Dr. Matthew Bramlett, very exciting. The work you do all around is very exciting. Thank you for sharing a little bit of it with us today.
You're welcome. Thank you for having me.
And thank you for joining us for this episode of OSF HealthCare Accelerated. And remember, you can find all episodes at osfhealthcare.org/accelerated.